No. Still some places are empty. I'm sure somebody, you'll also take some afternoon nap also, so all the best for you. Because this is not the right time to talk, immediately after the lunch. Anyway, so what I'm going to say today is not new, because you might have already read the World Health Report 2010. So I'm just going to repeat what is present in the report. To say about World Health Reports, this is the 15th one. So we started publishing World Health Report in 1995 for the first time, when we started talking about bridging the gap. We are still talking about it in 2011, bridging the gap. So which means the world remains where it was 15 years ago. Maybe issues have changed a little bit here and there, and some problems were solved, but not all. So what you will see from my presentation is, you will see some repetitions of issues which you might have already talked about. And today morning also we talked about issues which are already there in the World Health Report 2010. So the issues are not different, they are same. But what we are going to add in this World Health Report 2010 is what are the issues concerning financing which are disturbing the attainment of universal coverage. So that's one which is new in this World Health Report. And also what are the possible solutions. If you read 1995 report, it clearly says that statistics or data is missing from low-income countries, particularly on resources and their use. That's a fact even now, but though we have improved quite a bit in 15 years' time. So you'll find a lot of details about financing in the report, and also some solutions which are being practiced in particularly in low and middle income countries, though we are talking about high income countries as well. So essentially I'm going to talk about three issues in maybe 18 minutes. The first is, what do we mean by universal coverage? It is still a debatable issue because no clear definition can be provided for universal coverage. You can see the literature that people are defining universal coverage in different sense, suiting whatever their context. And second is, how universal is coverage, particularly from a financing angle. And third is, what are the solutions? What are the possible solutions? So we have to make the distinction very clear here that universal coverage is one thing and financing is an instrument. So we are not saying in this report that financing is the sum total of universal coverage. It is not. It is just a pathway. There are so many pathways, and financing is another pathway to achieve universal coverage. But you can see in many low-income policies, if you read, this part is really weak. Financing is reduced simply as costing tool. What they do, they prepare a wish list and then they cost whatever is there. And that's the reason they will say, finance is inadequate and things like that. So it's partly because, financing is not handled that well in low-income countries. And we are hoping through this report, it will reach a better way of defining financing and solving issues related to financing. So what is the universal coverage? About universal coverage, I think you will see a lot of discussion in the 2008 World Health Report, and this figure is just from that. So it is particularly talking about intersectoral integrated approach, and universal coverage is employed in a little broader sense to include intersectoral actions also. And particularly, this World Health Report 2008 talked about people-centric care. Because you can see in many systems, the system is defined from a supply perspective, from a supply of resources, or from a hospital, from healthcare centers, from that perspective. And this particular report talked about the demand side as well. So there are a lot of arguments in favor of empowering demand side and bringing them to the table for discussion. So what is universal coverage as we see it right now? Universal coverage, if you can see the World Health Assembly resolution, which is essentially driving the World Health Organization, is that it is coverage for all That is, nobody should be discriminated against. That's number one. Number two, without any financial risk. So there should not be any financial risk. Because of financial barriers, people should not be denied access to care. So these two are the real points in that resolution, and that is borrowed as the universal coverage definition. So in this World Health Report, we are talking about three things. You might have seen the three-dimensional box figure, which talks about three things. One is coverage of health services. By health services, we are not talking only about curative services, we are also talking about promotive and preventive rehabilitative services. And then financial risk protection, that is the second pillar we are talking about. And third, most essential thing for all. So this is the sort of magic box which is being widely referred also to bring in universal coverage arguments. And you can place your context in this box. As you can see, one dimension is for population, that is who is covered, how much proportion of people are covered. This is applicable to the other two dimensions also. The second dimension is health service coverage. So if you say health service coverage is provided to population, how much of the health service, that is what is the essential package and how much of it is really goes to what proportion of population. So that's one side. And the other side is financial risk protection. How many are having services without having to incur any catastrophic expenditure or without having been denied care to achieve this? And as we have been debating in the morning, we can see that probably the main issue in Canada is this box, the financial risk protection. And also listen to the morning presentations. Sometimes we get confused between costing and financing. When we say that it is very expensive to provide services in rural areas, it is expensive. But then if you cut that expenditure, somebody else will pay for it because they have to get service anyway. So it's about whether government should spend or people in those areas to spend. So it's not about reducing the need for financing. It is basically shifting responsibility from one another. So when we talk about cost of services, it is expensive to provide services in difficult areas. For two reasons. One is they are difficult areas. They are difficult in so many ways. And probably they also suffer from multiple inequalities. So that's the reason it becomes doubly expensive to provide service. You can also see in many countries, when you try to assess the cost of providing care, for the first 10% of population it will be easier. As you reach towards the 100% coverage, so 90 to 100% population will be the most difficult one and probably maybe the most expensive one also. So we have to make the distinction between costing and financing, and probably in many developed countries probably is financial risk protection, which is a major issue. How to contain cost and how to reduce reliance on out-of-pocket spending, particularly co-payments. And the report talks about the gap in financing and the gap in service provision. So the world is still a long way to go. Maybe some countries are closer to universal coverage, but some countries are really far. As you can see, 150 million people suffer from financial catastrophe each year. And I'll also give details of which region has more catastrophic expenditure. And then 100 million people are pushed into poverty because of this reason. There are studies which are analyzing poverty incidence in different countries, and studies have shown that poverty has gone up by 20, 30, 40% in low-income countries because of paying for health services. Because this is one thing which they can't avoid, and some people they lack care, and some people just borrow a high-interest loan and all to pay for health services in low-income countries. So this is the kind of distribution across WHO regions. On top is the EMRO region, that is the Eastern Mediterranean region, that has the lowest impoverishment and catastrophe. Doesn't mean that they are enjoying very good care. It is probably they are not linked to the healthcare delivery system. They don't have to incur expenditure because of that probably. And the African region, they have more catastrophic expenditure, also impoverishment. This is again because they are not able to access health services. So these are the people who really try to access the system and then incurring expenditure. And then the maximum is in the Western Pacific region, where about 80 million people are, incurring catastrophic expenditure. Around 40 million people are being impoverished every year. And American region, also there is a catastrophic expenditure. Impoverishment is relatively less. And Southeast Asian region, impoverishment is higher than catastrophic expenditure. Again repeating that these are the people who gained some access and then try to spend money. There are quite a lot of people, probably a billion or so, they don't access anything. So what are the diagnoses? There are two basic factors. One is exclusion linked to factors outside the health system, and another factors which are within the health system. That is what probably Ministry of Health can control. The other thing is, multiple inequalities which cannot be controlled by Ministry of Health, which requires coordination with the rural development, social welfare, other ministries also. So these two combined together, they act to cause some hindrance to the healthcare access, particularly in low and some middle income countries. Health financing system is also not understood very well, and they are often not well defined. Partly because we have been debating in the morning about the split between provider and purchaser, but it may look like a little advanced issue in low-income countries because they don't understand what it means. Both are sort of existing together. But some countries are trying to distinguish between purchasing and providing. For instance, we talked about Ghana, they try to differentiate through their NHIS, and there are other countries which are now trying to differentiate between these two. So there are three fundamental challenges in financing which are not new. The first is the need for resources. And morning we discussed about too much of resources or mishandled kind of resources. But in low-income countries it is the opposite. They need resources, it's very less. And second, the need to really organize resources well. Right now, the bulk of the resources, they are coming from out-of-pocket spending. What it means, they just have to carry money at the time of illness. So they are doubly disadvantaged at that time. They are ill, and most of the population, they rely on casual work. So if they don't work, they don't have money. But if they don't have money, they can't access health system. And if they can't access healthcare, they can't work next day. Their productivity is lost. So it's a very multiple kind of issue. So what they do, they try to raise a lot of high interest distress loans. Sometimes it goes to 500-600%. It's very high, very exorbitant rate of interest. So they buy such resource because they have to be ready for work next day if they have to be fit. And third is also, which we have discussed in the morning, governance and inefficiency issues, which are also common. But in low-income countries, I don't know how much we can save out of efficiency, but still it is considerable. But the main issue is lack of resources. So in low-income countries, it's very low because the World Health Report says that we need about $65 per capita in 2015. These figures keep changing. If you have read the Macroeconomic Commission report, it talked about $34 per capita, and now it is 65 in 2015. But it all depends on what you are including in the basket. So the amount is not very fixed, but this is a rough estimate of how much we need to provide at least a minimum essential services. But as you can see, even with the positive trend in the economy, many countries, or 60% of the countries, may not reach that level by 2050. So they need support from outside. And in Africa, at least, Abuja Declaration has resulted in some discussion about this, and many governments have succeeded in increasing resources to health. So that's a good thing in Africa, and many countries have really benefited from that kind of declaration. High-income countries also, of course, their needs are different because of the technological advances, because of old age populations. So they are into the expensive care region. So for the low-income countries, it's about malaria, it's about HIV/AIDS, and it's about basic illnesses. They haven't graduated up to that level because they don't live that longer to get non-communicable diseases. But they are also coming up now in low-income countries. But in high-income countries, it's about high-cost care because of the population demographic transition. So this gives a picture of the government spending on health as a percentage of total government expenditure. It is the budgetary share, we can say. As you can see, where the resources are required the most, they are the ones spending the least, particularly in South Asia and Africa. So they are not able to mobilize resources, and that's the reason they are spending less. Like people, governments are also poor. They have their own limitation to raise resources. If you can see the tax GDP ratio between high-income countries and low-income countries, you can see that low-income countries are struggling to reach around 15% of GDP to raise as tax. But in high-income countries, it's about 30%. So they are not able to bring in more resources in general, and that's the reason governments struggle to find resources for health. So the first issue is to find sufficient resources, and second issue is financial risk protection. Here we are talking about direct payments to providers by consumers. Because they have to pay directly to the providers, some people, they don't go for healthcare because they know that they don't have resources. And we listened to Ghana's presentation also about the cash and carry and how it prevented people from going to the formal providers and went to informal providers or no care at all. So that's the problem with the direct payments. If you make them to pay directly, either they don't come or they raise high interest loans. And also there are studies which show that countries which are having less out-of-pocket spending, they are having very less catastrophic expenditure, and they are also having very less financial hardship linking to that. But we have to be a bit cautious about out-of-pocket spending, because if you don't provide anything also, there will be less out-of-pocket spending, particularly in low-income context. So without too much focus on this 15-20%, we have to be a bit cautious. One interpretation of this will be that if there is enough provision for prepayment and government spending, and that's the reason people are not required to spend less, required to spend more, and therefore out-of-pocket spending is less. That's a good welcome scenario. But there can be also another scenario where people don't go to health center, and that's why they don't spend at all. So when we focus too much on that, this 15-20%, it will be sometimes very difficult. We should not focus too much on that. But at the same time, we have to go to the first part, that is the positive side of making it less, not the negative side. And third is inefficiency, which is very much in all countries, high income or low income or middle income. But governance issues are quite common, unfortunately, even in low spending countries, where resources available are very less and they are not reaching really to the needy. And different estimates talk about different proportion of resources really reaching the target. And there are even corruption ranking and things like that. So you can read that report to find out which country stands where. So partly it is because of corruption, and partly because of spending it on wrong things. So they are not spending it right, and they are not spending on right things. For instance, nobody has analyzed whether out-of-pocket spending is spent efficiently or not. Whenever we talk about efficiency, we talk about government efficiency. We don't talk about private spending, that is household out-of-pocket spending, whether really they are spending on treatment or they are spending on tonics and vitamin tablets. So we don't know where it is spent. So inefficiency is there in many forms, particularly in medicines and the use of technologies. But then morning also the figure was referred, if efficiency is improved, probably we'll have around 20 to 40% more resources for healthcare. So what are the possible solutions? And here we are talking about two things. One is what countries themselves can do in the time ahead. That is to raise more resources, though it is very difficult for governments to raise resources given their limitations, but still it is possible, there is scope. And second is to increase financial risk protection. This is the area where many low-income countries are lacking really. And then more efficient and equitable. So if these three issues are addressed basically from a domestic angle, then possibly they can move closer to universal coverage. This is not something new, which many countries are already doing. It's about process. How to design the health financing system and how to reform it. So the first step is vision. What is a vision? It's lacking in many low-income countries. If you look at their policies, there is no vision. Of course, they will have vision, but which will be achievable in about 150 years' time sometimes. It's all dreams. So there is no achievable vision for a limited period of time with which they can do something. So that vision is missing from many countries. So the action one recommended by the World Health Report is start with a vision. Where do you want the country to be in 10 years' time or 20 years' time? Start with that thinking and then see what is achievable within that period. So first is about vision, and second is situation analysis against that vision, and then what are the financial requirements and what are the financial possibilities within the context, and how to raise resources, and then what are the constraints and bottlenecks and how to overcome. That's step 4. And 5 is strategy for change for better, not for worse, and then implementation of this strategy. Then the cycle goes like that, monitoring, and then comes back again to the situation analysis, vision. So this is how the health financing systems evolve over a period of time. So it's nice to have a vision for next 10 years, and then start, and then after 10 years you see the vision again through the same cycle, and then see where we are, and then refine the vision, and then go ahead. This is the recommendation from this World Health Report. So number 1, we have been discussing about government spending, which is very low in low-income countries. So increase government priority, which can be reflected in the higher health spending. So that is number 1. So for instance, 45 governments, they devote less than 8% of their spending to health, and 14 devote even less than 5%. Many of them are in Africa and Asia. So Abuja Declaration, because of that, some African countries, they have really achieved the Abuja target, to be precise 3. And some of them are closing in. So you can see in Africa, many governments are spending around 10% of their budget for health. But in Asia, it will be much less because there is no push in specific direction. So the key is raised more domestically. Then only the system can be much stronger. Because it's a system-driven thing, and all the bottlenecks can be removed domestically, not rely too much on external resources. And there are some suggestions. For instance, in Indonesia, even a perfect tax collection has resulted in about more than a % increase in tax collection in Indonesia. So there are possibilities of improving domestic resources if efficiency improves, not only within health but also outside. And Ghana has shown the way that value-added tax can be used for financing health. So 2.5% of the value-added tax is used for this purpose. Sin tax will be sometimes controversial, because when we start taxing some items like tobacco or alcohol, indirectly it may be seen as promoting them, because you tend to increase tax from these resources, which means you are indirectly promoting. Because of that, you are also increasing the disease burden. So it's not very easy to talk about sin tax. And also in many low-income contexts, Many farmers also cultivate tobacco. So it's not very easy for them to raise such resources because they are also producers of tobacco and they will also be users of tobacco. So this is a dilemma in many low-income countries. And also there are other suggestions like solidarity levies, especially there are foreign remittances, there can be tax on that. There are so many other examples which are provided in the World Health Report. So prepayment is the only solution for this financial risk protection. There is no other way. Either it can be through tax or it can be through insurance. Whatever be the case, so it should be prepayment, not at the time of distress. And there are a lot of examples which are now coming up, trying out a lot of different things like demand side financing, national health insurance model, like in Rwanda, Ghana, and also in South Africa now they're trying for that. India has come out with something called RSBY, which is a targeted insurance scheme for poor people. And there are also community-based and micro-insurance mechanism. One distinction between community-based insurance and micro-insurance is a for-profit approach, whereas community-based insurance is a not-for-profit approach. But in the literature we can see people use both interchangeably, but which is not right. So this is another area, along with the financial risk protection, it is necessary to protect the poor, whichever country we are talking about. There is a big chunk of people who are not able to access services because they are poor and they don't have resources. And there are again a lot of examples discussed in the report, like free subsidized services, which is under the National Health Service model or the beverage model. And then subsidized or free enrollment in health insurance, as shown in Thailand, for instance. And also there are conditional cash transfers now coming up, basically to strengthen the demand side. You put the money into the hands of people and let them decide where they want to seek services. It is based on some conditions, including some preventive care and also health seeking. Greater efficiency, also there are a lot of examples available in the world, but it is more context specific also. Particularly the branded medicine versus generic, it's again another debatable topic, where people spend a lot of money on branded medicines unnecessarily, which may be 6 times, 7 times higher price when compared to generic medicines. The generic medicines, there are problems of quality and a lot of heterogeneity in there. It's very difficult to control quality. So that's a dilemma also. So what can international community do? With all their domestic efforts, we can understand that low-income countries are disadvantaged. They have their own limits with which they can raise resources. So certainly they will need resources for another maybe 20-25 years till they become really, economically self-sufficient. One of the problems with international donor support is they promised 0.7% of their GDP for low-income countries, but they have never achieved that. It's close to 0.3%. So it's less than 50% of their own promises. So if they just fulfill their promises, it will be enough to really serve poor countries, at least to provide essential services. And there are also other ways of innovative financing mechanisms internationally. And you can read the report to find what kind of approaches like airline taxes, also debt to health and all those issues, all those solutions are possible. Another problem with global funding or external funding is that countries are required to obey a lot of conditions, and particularly they have to report to these donors about so many indicators, and countries spend a lot of time and effort on these alone. For instance, in Rwanda they have to report 890 different health indicators to donors. So they have to spend quite a lot of time along with their own routine work. So where is the time for providing care to people? So that's one issue. And health missions, international missions are another bigger problem in developing countries. So they have to be, all these big bureaucrats are engaged in that, and there is no time for for them to talk about people's issues. So that can be reduced so that the conditionality can be reduced. Thank you, and open for discussion.